Good afternoon. Like Catherine, we're going to use back pain to talk about what it is we are doing, not thinking about doing. Here's some data to establish context. If we look at back pain, non-surgical back pain, 30% start with PCP, 40% specialist, 31% chiro, PT, acu, OT. Total episode costs are to the right. The way to interpret that, blue is how much we spend with the first provider seen. So PCP, blue is how much did we spend with the PCP. Green is how much do we spend with other providers that practice with the first provider. And where this gets interesting is orange. When the patient leaves the first provider to go into the delivery system and get other services from other providers for the same episode of the same condition, what do we spend and who's seen? And the orange is where we see chiro and PT and acu stand out, meaning we make the investment in blue with chiro PT, the orange piece of the bar collapses pretty significantly from the other options. So that's where the total episode savings is occurring. And the dollars with the prevalence of back pain is real, and we'll talk about that in a moment. Below are the attributes of the episode, starting with these pathways. Number of different providers seen, fragmentation. How likely are you to receive recommended therapies? How likely are you to receive therapies the guidelines suggest you shouldn't be receiving? How likely are you to receive imaging and at what time in the episode? And in green, the pathway that's most aligned with all prevailing guidelines are when patients start with chiro, PT, acupuncture. Least fragmented, you receive the services you should, you avoid those that you shouldn't, imaging is aligned, total episode cost is lowest, that's attractive, yet only 30% of patients are starting with the ideal pathway. So what are we doing, like actually doing? And this is sort of our roadmap. And so if we start on the left, patient with back pain consults a variety of sources of information to decide what to do. They go down one of these three pathways, primary care, specialist, or conservative. There's the 30, 40, 30% front door. Our ambition, our goal is in 2 years is to take the front door access to conservative care from 30% north of 50%, and then timely referrals from those that self-select a medical path to take that from 2% north of 10%. And collectively, the actuaries have done the work. It's presented at the actuarial conference that net of the increased conservative costs on our commercial book, this will take out about $230 million in annual medical expenditures and reduce opiate prescribing for back pain by 25 to 26%. So our ambition is leveraging two parts of this journey, the front door and then the side door, referrals to conservative care. And what are we doing? In A, start with, it's come up multiple times, file 2019 and 2020 benefit plan designs to include waiving out-of-pocket costs, whether they be copays or deductibles for consumers that access conservative care options for back pain. Plans are filed, extraordinarily complex to make that work at the scale that we operate, but a lot of calories are being burnt to make that a possibility in 2019, 2020. Surrounding that, whether it's print, digital, portal, telephonic, a variety of almost public service communication efforts to help patients and employers become better consumers of care for spine-related disorders. Another key point, we're at yellow, we're not going to get through all this, it's kind of ambitious, but at B, at this point where patients are deciding, okay, I'm going to go into the delivery system, provide tools and resources that are simple to understand what's wrong with me. Do I have a red flag which I should escalate immediately? If not a red flag, what are my options? Present preferences and range of options for your preferences. Based on those preferences, who are the providers, zip code, miles, minutes, gender, language capability, specialty, episode cost, that are sort of in your sort of set of preferences. Rack and stack those providers based on performance. We're connecting to practice management systems of these providers to see appointment availability in real time through their scheduling API layer to allow the patient to push a button, schedule with a provider that they choose to see, and ideally that'll be, in many cases, these conservative providers. So the point here is I have no out-of-pocket cost. Here's the providers available to me that meet my preferences. Here's who has an appointment this afternoon or tomorrow. Push a button, done. And then for the medical paths, primary care and specialists port that same kind of technology into their workflows by embedding into Epic and Cerner so that the medical physician can know, no out-of-pocket, here's the PTs and chiros in the community, here's who's open this afternoon, push a button, refer, and connect the dots. So again, our ambition is really to drive up access to these conservative therapies by almost doubling the current rate. And I do have an appendix. I'll leave you with a picture. This is the current state of spine care today. So the same 27,000 providers we looked at yesterday, all of them were the first provider seen for 25 episodes of back pain. Here's the likelihood of receiving an opiate or an imaging study at any time during the episode. The color is the specialty. Spine care is almost a perfectly random event today. So how does a consumer have any idea who to see, what am I going to get, what's going to happen to me? And sitting here today with the guideline clarity, this is just frankly unacceptable. And so the call to action is really for us, no more research, no more data, just make this happen. So the urgency is there, the restlessness is there, the bias to action is there, and that's where we're squarely focused. So thanks for the time. I appreciate it.